This presentation on intracranial regulation focuses on intracranial pressure monitoring. Now, before we discuss how to monitor intracranial pressure, it's helpful to be reminded about what is a normal intracranial pressure. What's a normal amount of pressure to have in your skull? Well, before we get into numbers, a reminder. High is bad. We aren't so much worried about having too low of a pressure in the skull. Obviously, negative pressure due to interventions and really rare situations would be bad. But rather, we are worried about ICP being too high. And I say this because there are different schools of thought on what a normal ICP is. So for example, your textbook says a normal ICP is 5 to 15 millimeters mercury. And a recent publication by the AACN summarizing the literature on intracranial regulation refers to normal ICP as 0 to 15. Either way, we would not be worried about a patient who has an ICP of 2, for example. That's not too low and doesn't require an intervention. What we do worry about is when it starts to go over 15. And when do we get really worried? When do we actually label it as increased intracranial pressure? That's actually when the ICP goes above 20 millimeters mercury and it stays sustained above 20. Also, in order to get that intracranial pressure number, we need a device that can provide that information. So many times, nurses are caring for patients with a suspected increase in intracranial pressure, even if we don't have that hard data to confirm it. We don't have that ICP number. So in the case of anyone becoming acutely unconscious, we should always suspect that that person could have an increase in their intracranial pressure and then conduct our nursing care accordingly. So first, let's review important points about nursing assessment of the patient with suspected or confirmed increased intracranial pressure. So what are those assessment findings that indicate our patient has increased intracranial pressure? Here you can see a list of common clinical manifestations, and it kind of makes sense. An increase in the pressure in the cranial vault would likely lead to a change in level of consciousness, so becoming maybe more fatigued or even unresponsive. Reflexes may also change, and we'll discuss the specifics of how vital signs may change here in a second. Headache is a pretty logical finding that we suspect from our patients, but also vomiting. And if the vomiting is projectile, that is especially indicative of increased ICP. Now keep in mind that in our brains lies the hypothalamus, and the hypothalamus helps us regulate body temperature. So if this increase in intracranial pressure has started to stress the hypothalamus, it may not be able to do its job as well. And we could see poikilothermia, where the patient is unable to regulate their own body temperature, resulting in abnormally low or high temperatures. And in general, it's important to remember that an elevated body temperature can increase metabolic demand, which increases ICP. So you can see how these can potentially become a cyclical process. Now, it's very important if you are to practice safe nursing practice that you can quickly identify the key signs of late increased intracranial pressure. These aren't those subtle changes in level of consciousness or that headache that's starting to build. These are late signs that your patient's ICP is much more advanced and thus much more dangerous. So 3 of the late signs of increased ICP are grouped into one term, and we call that Cushing's triad. And those 3 components of Cushing's triad are systolic hypertension with a widening pulse pressure, bradycardia, and an irregular respiratory pattern. So for example, your patient has a blood pressure of 190 over 85, a heart rate of 47, and you recognize as you're counting respirations that their respiratory pattern is irregular. So starting off with that blood pressure of 190 over 85, we have a wide pulse pressure. That difference between systolic and diastolic pressure is growing. And that systolic hypertension, that high systolic pressure, is actually the body trying to overcome the pressure in the skull, so it's trying to perfuse blood to the brain. It's pushing harder, in a sense, to overcome that increased ICP. So that's the first part of our Cushing's triad. Next, we have a heart rate of 47 in this case. Now, that's clearly bradycardia, and there are different schools of thought as to why this happens. Some argue it's compression of the vagal nerve. Some say it's baroreceptors responding to the hypertension, trying to slow down the heart rate to correct for that high blood pressure. Either way, a low heart rate is a sign of late increased intracranial pressure. And the last, in addition to that systolic hypertension with the widening pulse pressure and bradycardia, our patient's respiratory centers are being compressed due to that increased ICP. So we start to see irregular respiratory patterns. Now remember, these are ominous signs. These are late signs of increased ICP, and in some cases, terminal signs for our patients. So it is critical here that we can recognize Cushing's triad as an emergency. If the patient doesn't already have a drain in place, an external ventricular drain that could relieve pressure on the brain, this would be something the team should definitely consider. Now, in addition to Cushing's triad, patients also can present with posturing when they experience noxious stimuli or some kind of painful, uncomfortable stimulus. And this posturing could be decorticate, or what we call flexed, or decerebrate, what we call extended. So we'll take a look at what those look like on the next slide. So here you can see examples of posturing. Let's say you have to suction your patient's airway. That's uncomfortable, right? That's a noxious stimulus. And upon suctioning them, you notice that in response, their head turns away, their arms extend, and their hands extend, and their toes point. Those are extension postures or decerebrate posturing. And this is a late sign of increased ICP. Or maybe in another patient's room, you're starting an IV, another noxious stimulus, and this patient's arms tuck into their core. This is called decorticate posturing or flexion posturing. And this one can be easy to remember because we have flexion to the core for decorticate postures. Both of these responses to noxious stimuli are ominous and late signs of increased intracranial pressure. However, decerebrate, or that broad extension, is considered a more severe response. So if we were tracking a patient getting worse and worse and their ICP becoming more and more severe, they may start off with decorticate posturing, but over time, as things worsen, we start to see decerebrate posturing, which is really a sign, more of a sign of the brain being compressed. So as we talk about parts of the brain being compressed due to increased ICP, it's good to remember that our respiratory centers are in our brain. So here we have some examples of different abnormal respiratory patterns that we might see in our patients with increased ICP. And you can see the name of the pattern, what part of the brain is being affected, and the description of each here. I recommend taking a look at that visual pattern as well as the description of each so you can be able to identify these in your patients. Just keep in mind, if your patient is mechanically ventilated and sedated, it could be difficult to identify these breathing patterns. As you can imagine, pupillary responses can also be affected by intracranial pressure. So obviously, we would expect normal pupils to be equal in size and react to light briskly and equally on both sides. Now, it can be helpful to review sympathetic and parasympathetic pupillary responses to make sense of all of these. So remember, a sympathetic fight or flight response where we need to take in a lot of light so we can see some potentially dangerous event, that's going to result in pupillary dilation. So sympathetic is pupillary dilation, and parasympathetic is going to present as pupillary constriction. And our ocular motor nerve, that third cranial nerve, innervates the pupils to constrict and dilate. Now, when the brain begins to swell and we see increased intracranial pressure, that swelling actually interrupts the parasympathetic response, but not the sympathetic response. So remember, that means it's going to interrupt the constriction, parasympathetic, but not the dilation, sympathetic. So a pupil that is dilated or even not responding to light quickly, that pupil is demonstrating those symptoms on the same side as the swelling in the brain, or ipsilateral. So for example, if the right pupil is sluggish to respond to light, the right side of the brain is experiencing swelling. So looking at a patient who has sluggish pupils, where we shine the light in their eyes and the pupils constrict slowly, that is a sign of pressure on that third cranial nerve on that side. Fixed pupils, where they do not respond at all, are a sign of increased intracranial pressure. And remember, it's ipsilateral again, so a fixed pupil on the right means increased ICP, specifically on that right side of the brain. And if pupils are fixed bilaterally, so not responding to light at all on both sides, you've shined a light in your patient's eyes and there's no constriction at all on either side, and both pupils are dilated. This is also referred to as fixed and blown pupils. This is an ominous sign that the patient has potential diffuse brain injury. Now you may see pinpoint pupils, which is a parasympathetic response. Remember, constriction is parasympathetic. So this could be a side effect of CNS depressants, basically imitating parasympathetic responses, so possibly something like a heroin overdose. Keep in mind that pupil shape and size and reaction can also be affected by factors outside of intracranial pressure. Things like mydriatic eye drops, drugs, injuries, or surgeries to the eyes that can also result in pupillary changes. So it's always important to have a thorough health history of our patients. Now, one more thing to think about. How many times have you looked at a patient's pupils and thought, did they react? I'm not sure. Or are those 3 millimeters or 4 millimeter pupils? Pupillary assessment can be really subjective and leave a lot of room for human error. So research is showing more and more that an objective pupillary assessment, especially in these high-risk settings, can be invaluable to patient care. This is where pupillometry comes in. And pupillometers scan the patient's eyes and provide an objective measure of pupil size as well as reaction. So think about it. This can mean the difference between thinking a patient has fixed and dilated pupils or just sluggish pupils, which can really weigh heavily on our patients' plans of care. Here's another important tool that we use when conducting neurological assessments for our patients, whether or not we're concerned about an increase in ICP. This is called the Glasgow Coma Scale. And while this scale is broadly used and understood, it's far from perfect or comprehensive, but it is a very quick and efficient way to determine some basic neurological information about our patients, specifically level of consciousness. In the ICU, we traditionally do this assessment with sedation medications turned off so that we can get the most accurate number. Now, the GCS is a numeric scale of up to 15 points, where 15 out of 15 is normal, and the lowest possible score is 3 out of 15. This score is made up of 3 categories that relate to our neurological status: our eye response, our motor response, and our verbal response. So taking a look here in the eyes category, if you walk into the room and your patient is awake and looking around, they just received 4 out of 4 points in this category. However, if you walk into the room and their eyes are closed, you then talk to them, and maybe you have to yell a little, and you see, do they open their eyes now? And if they did, then they get a 3 out of 4. If they still haven't opened their eyes, then do they open their eyes when you cause them pain? If yes, then they get 2 points. And if still nothing, now they get the lowest possible score of 1 point. So moving to motor response, if you ask your patient to do something and they do it, they get 6 out of 6 obeys commands for this section. Just remember, not all patients in the ICU are very mobile, so we try to ask them a few times if they're having a hard time with this section. So for example, I might ask my patient, show me 2 fingers, but their hands are so swollen and they can't show me 2 fingers. So in this case, I might ask, stick out your tongue or raise your eyebrows. A patient that can clearly respond to those commands with an appropriate motor response would still get 6 out of 6 points. However, if I've asked my patient to show me 2 fingers, raise your eyebrows, stick out your tongue, and I see nothing, we now have to observe responses to painful stimuli. And this is when it's helpful to be monitoring eye response at the same time as motor response, so I don't have to cause pain twice. Now, if in response to a painful stimulus, the patient reaches to that area, making a purposeful movement to try to change the stimulus, that is called localizing and would be 5 out of 6 points. However, if they only pull away from the stimulus, this is called withdrawal, and it's 4 out of 6 points. Next, as we discussed previously, if the patient's response to a painful stimulus is with a full body posture, so decordicate flexion posture, that would be 3 points. And if they have an extension or decerebrate posture in response to painful stimulus, that would be 2 out of 6 points. Now, if the patient doesn't respond at all to painful stimuli, then they would get 1 out of 6 points here. So just keep in mind, there are different approaches to how we can cause painful stimuli in our patients, but it's always best to try to determine if there's something painful you already have to do with your patient, and then monitor their response to that first. So for example, if I need to suction my patient, that can be really uncomfortable, so I could monitor my patient's motor response to suctioning rather than causing them pain. So for example, if I suction my patient and she tried to reach for her endotracheal tube, that would be localizing, and I would be done. I wouldn't have to cause further pain. Just keep in mind, if there is no response to this suctioning, I may still have to cause my patient pain to make sure there truly is no response. This could look something like squeezing the trapezius muscle or applying pressure to the nail beds. Before I give my patient a 1 out of 6, I need to make sure I've been thorough. Maybe they didn't respond to suctioning, but they did pull their arm away or withdraw when I pushed on her nail bed. Now last, looking at that third section, verbal response, now I want to see if our patient can speak in a meaningful way to us. If my patient is oriented and converses, then that would be 5 out of 5 points. Now, if they can still have a discussion with me, but I start to realize that they don't know where they are, or maybe they don't know what year it is, that would be 4 out of 5 points. If my patient still has the neurological capacity to form single words, but these words make no sense in the context of my discussion with them, they get 3 out of 5 points. And if they can make sounds like moaning or grunting, but no actual words, then they would get 2 out of 5 points. And obviously, if they have no verbal response, the score is 1 out of 5. Now, you may be asking, what if they're intubated? Maybe they could talk if they didn't have that tube in place. Do we guess? Do we tell ourselves, he looks pretty oriented, I bet he could talk with me? No, we don't do that. We don't make any guesses. Our intubated patients can't talk, so they would all get 1 out of 5. But we do put a little T next to their total score so that those making sense of our assessment information can understand that the patient is intubated. Now, one last thing to remember about the Glasgow Coma Scale, for total GCS scores of 8 or less, this is considered a coma. And in those cases, we should strongly consider mechanical ventilation and an external ventricular drain for ICP monitoring if those aren't already in place. Now let's talk about how we take care of patients with increased intracranial pressure. So our patient has increased intracranial pressure. How do we take care of them? How should we position them so that we don't make the ICP go up more, but also promote normalizing ICP? Well, first, we want the head of the bed to be elevated since that will allow venous outflow from the head, but still promote good perfusion to the brain. So unless contraindicated, we try to keep the head of the bed at 30 degrees. And this also helps our patients breathe better. And we want to avoid any neck flexion since that would inhibit venous outflow. And if possible, it's also helpful to avoid any unnecessary hip flexion since this can impede venous outflow as well. Our patient with increased ICP may not be able to reposition themselves adequately. So turning every 2 hours, monitoring for breakdown, injuries, and even hemorrhage is important. And as we know, both pain and anxiety can be prominent issues in the ICU. So these are already considerations for our patients with increased ICP. However, remember that both pain and anxiety also increase metabolic demand, which can further increase ICP. Now, psychosocial issues, as you can imagine, can be very complex when considering what could have surrounded our patient's state with increased ICP. Was it a car accident? Was it some sort of trauma or interpersonal violence? Providing support, reducing anxiety, and considering the needs that affect our patient, any family at the bedside, it's really important. And one of the common things we'll be doing as we care for patients with increased ICP is reducing stimuli. Anything that could increase intracranial pressure. This includes environmental stimuli like noise or bright lights, but also, as we've mentioned, of other causes of increased ICP, anxiety, pain, fevers, seizures, and stress. Those can all increase intracranial pressure. So we need to do what we can to prevent those problems from happening. And that includes remembering that suctioning is stressful. It doesn't mean we don't suction our patients who have increased ICP, because airway is critically important. It just means that we need to be judicious with our suctioning and keep this to less than 10 seconds. Also, abdominal distension can translate into decreased venous outflow. So we need to do what we can to reduce that abdominal distension. And sometimes this means preventing or treating constipation. In other cases, it may mean a nasogastric tube to decompress the stomach. Now let's look at some more aspects of nursing care of the patient with increased intracranial pressure. If our patient has increased ICP, frequent neurological assessments are going to be a key way we can catch decline in our patient status or if they're improving. And usually these are done about every 1 to 2 hours, but you always want to refer to your unit policies and physician orders. Our neurological assessment includes a lot of important components like pupillary assessment, motor strength and symmetry, Glasgow Coma Scale score, and so on. Now let's think about potential safety considerations. patients with increased ICP are at increased risk for seizures, so it's often part of our care protocols to institute seizure precautions. Also, if a patient has increased ICP, they may be confused or compulsive or unpredictable, and they often have a lot of very important indwelling devices and IVs and central lines. So this is why you might see patients in restraints. Just keep in mind, some recent research is suggesting that restraints may not help too much. Putting patients in restraints can increase anxiety, and many patients still manage to pull out important lines even when they're restrained. Therefore, sometimes IV sedation is used in addition to or instead of restraints. Now, it's important that we keep these patients normotensive, hydrated, and that they have adequate nutrition. Sometimes we even allow a patient's blood pressure to be a little bit higher than normal to ensure adequate perfusion to the brain. Now, family involvement can be complex. As we mentioned, there could be important context to consider when allowing certain family members to visit. And while the patient may not be able to talk to you or even communicate with you, they can often sense the presence of who is in the room or hear their voice at least. And if there is a visitor with the patient, watch the patient's ICP number on the monitor. Is it going up? This could indicate that the visitor is causing enough stress that we may have to ask them to leave. And this can be a little bit tricky sometimes. But one way to phrase this to a loving family member who just doesn't want to stress out the patient is to say, "It looks like your family member is really excited that you're here, but we need them to relax. And I think it would be best for you to step out of the room for a little bit." Now remember, the overall goal is to prevent further injury for our patients. We want to maintain a normal ICP and perfuse that brain adequately with good blood flow. If a patient had a primary head injury that increased ICP, and then over time their ICP increased more, causing some kind of herniation, for example, a secondary injury just happened. We need to prevent things from getting any worse than they already are. We need to catch increased intracranial pressures and intervene accordingly. Now, as you may recall, our oxygenation and level of carbon dioxide can affect blood flow to the brain. If our patient is showing signs of not breathing well, so that would look like low oxygen levels and high CO2 levels from hypoventilating, that hypoventilating results in cerebral artery vasodilation. That's going to increase blood flow to the brain, which is usually a good thing, but not when you already have increased ICP. Now, if we look at the opposite, our patient that is breathing really well or hyperventilating, they're taking in a lot of oxygen and have a high oxygen level or a high PaO2 and have low carbon dioxide levels from hyperventilating. They're going to have cerebral artery vasoconstriction, which will reduce blood flow to the brain, which is a perfusion problem. Now, many years ago, we used to intentionally hyperventilate patients so that we could reduce blood flow to the brain to reduce ICP, which would happen. But while we were doing that good thing, lowering the ICP, we were simultaneously doing a really bad thing. We were reducing blood flow to the brain, causing cerebral tissue ischemia. So we don't do this anymore. We closely monitor ventilation and oxygenation, and we do not intentionally hyperventilate our patients anymore. Now, in addition to the care we've talked about, certain medications may commonly be prescribed for patients with increased intracranial pressure. So one of these is an osmotic diuretic, mannitol, and this drug causes urination or diuresis by increasing the osmolarity within the nephron in the kidney. And by doing this, we're eliminating extra fluid that is increasing ICP by pulling that fluid out and excreting it through the kidneys. Another drug for increased ICP is hypertonic saline. So you may have heard of isotonic fluids like normal saline, which is 0.9% sodium chloride, for example. Hypertonic saline has more solute, has 3% sodium chloride, and it has a higher concentration or higher osmolality. And we do commonly see 3% sodium chloride used, and it essentially decreases cerebral edema by being hypertonic. That extra sodium chloride in the blood acts as a sponge by being a concentration gradient, pulling extra fluid into the bloodstream out of the brain. And one of the key precautions to be aware of with hypertonic saline is that it must be given slowly and traditionally through a central line. We do not want to see rapid changes in sodium levels, as this could result in rapid shrinking or swelling of the brain. Now, as mentioned before, patients with increased ICP are at increased risk for seizures, and those seizures can also increase ICP. So drugs like phenytoin or Dilantin can be appropriate prophylactic or treatment measures. And we also may see patients receiving corticosteroids such as dexamethasone, and these would be administered to patients to reduce brain swelling, maybe caused by a tumor or a mass or other injury.